All right. Hello. Good morning and good afternoon. And thank you for joining today's webinar hosted by NMS Labs. My name is Tiffany Scott, and I will be moderating the first portion of this webinar before turning it over to our featured presenter, NMS Labs Director of Toxicological Services, Dr. Laura Labay, who will present Tolerant or Intolerant, learning from studying drug concentrations in the living and the dead. Now, before we get started, let's go over what you can expect during our time together today. One second, I'm noticing some technical difficulties with the slide advancer. There we go. All right, so first we'll start with opening remarks so that everyone is prepared to get the most out of the webinar. Then we'll move into what we are all here for, and that is learning from Dr. Labay, who will take us through her talk. And then lastly, upon concluding the presentation, Dr. Labay will address your questions in the time that we've designated specifically for Q&A. This final segment is going to be moderated by my colleague, Reynolds Dyson. All right, so a few notes before we get started. This webinar is being recorded, so all participants will be muted. Also, there will be an email that will include a link to the recording so that everyone can have access to this recording once it becomes available. And then also, we're going to invite you to ask questions. So regarding the questions, we do encourage you to ask questions as you think of them during the presentation using the chat feature. The NMS team will collect your questions from the chat so that Dr. Labay can answer as many questions as possible after her talk. So let's review how to ask questions using that chat feature on the next slide here. So here, when we're going over how to ask a question, the first step is that we're asking everyone to click the orange arrow to expand the webinar console menu. Then you'll want to click the arrow besides the questions tab to open the chat feature. From there, you can type your question in the chat box and hit enter to submit your question. Again, you are welcome to ask questions at any time with this chat feature, and we will respond to your questions during the Q&A session at the end of the presentation. And with that, we are now ready to transition to our speaker, Dr. Laura Labay. So Dr. Labay, please unmute yourself as I transition control of the presentation to you now.
Okay, hi everybody. My name is Laura. I am a forensic toxicologist and the director of Tox Services at NMS Labs. And I am here today to talk about tolerant or intolerant and learning from studying drug concentrations in the living and dead with a focus on case interpretation. So how does a forensic toxicologist do what they do? There's, of course, the analytical component to forensic toxicology. At some point, to do an interpretation, you have to be able to know what's in the sample, what drugs are in the sample, what drug metabolites are in the sample, and if the sample is positive, how much of it is there. But to do a complete case interpretation, we really need to look beyond the toxicology findings. And to do that, we evaluate as much information as available and needed to determine the effects of the found substances upon the individual. Toxicology or good toxicology starts at the scene investigation. Are there pill bottles around? Are they empty? Is there any other evidence there of substance abuse? Does this look like a natural death? And that's just an example. But the toxicologist will want to know some information about the scene, especially for some case interpretations. Then we have the autopsy findings to consider. We want to know if there's another competing or overriding cause of death. We have to remember that some drugs, like the medications and the over-the-counter medications, are good. They provide therapeutic benefit for a variety of medical conditions that somebody may experience. We also know that a lot of people walk around in this world with drug in their system, with medications in their system, with recreational and illicit drug in their system, and they're not deceased. They may be intoxicated, but they are not deceased. And in some of those people, cause of death certainly can be attributed to the drugs, but in other cases, somebody might have another competing cause of death and they have drug in their system. So really, to do a complete case interpretation, you don't want to practice toxicology by looking at the numbers in absence of other case information. To do a complete interpretation, so there's a multitude of different factors that somebody may want to take into account. When I get a toxicology report in my hand, the first thing I am doing is to, I think something happened to the slides. The first thing I'm doing is I'm looking at the drug findings and I'm looking at the matrix. But like I said in the previous slide, it's really beyond that. In 2019, the American Academy of Forensic Science Standards Board, ASB, published a consensus-based document called Guidelines for Opinions and Testimony in Forensic Toxicology. And part of that, there's a section in that standard. It's sections 5.2 and 5.3. And they address best practices for the interpretation of drug concentrations by toxicologists. Specifically, the first sentence of section 5.3.I states that a toxicologist should not opine as to the effects of a drug or combination of drugs on a specific individual without the context of a given case. Because without the appropriate training to interpret analytical results in relation to functioning of the body, there's an inherent risk that exists that a postmortem case may be misdiagnosed. And I just listed some of the factors here, but there are others. For example, when I look at patient demographics pretty quick, it's usually on the top of a toxicology report. I want to know the age of a person, the matrix. So typically that's going to be blood, but it could be vitreous fluid, it could be urine, it could be tissue. And we know those matrix types, they're not a one-to-one change. So a drug concentration in liver is one thing, a drug concentration in blood may be something else. So the matrix source, especially because of postmortem redistribution, we need the toxicology findings, we need the concentrations, we need to know if the drug is capable of postmortem redistribution, which is a change in drug concentration depending upon factors such as diffusion or protein binding. Pre-existing medical conditions that may make an individual susceptible to lower concentrations of the drug. And I can just rattle off some more here. Pharmacodynamic effects. Is the rate of somebody's metabolism or rate of elimination affected? Is there a disease specific that can impact hepatic and or renal elimination of the drug? We also have to look to see if the drugs that are found in an individual, if they can produce an additive or synergistic effect. You don't want to have 9 drugs in a toxicology report and go down the list and be therapeutic, 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 and they're all CNS depressants. And now there's at least an additive effect of those drugs on an individual. We want to look for the possibility of adverse drug reactions. And then lastly, so here's the point that we're here today to talk about, is drug tolerance. And from a toxicology report, you're not going to get information about how long a person was taking a drug and how used they are to having that drug in their system. So just to start, there's a difference between tolerance, dependence, and addiction. I think like sometimes these words are used interchangeably, but they really mean different things. So to start, the operational definition of tolerance is a decrease in effect following repeated or prolonged administration of a specific dose. From a pharmacological perspective, it describes the reduced reaction to a drug following its repeated use. So for the individual to have that, the benefit of the drug or how the drug makes an individual feel, they may have to take an increased dosage of the drug. They might have to take a larger amount with the same frequency, or they might have to take the same dosage with greater frequency. But because they're tolerant to the drug, they do need that in order to feel the effects of that drug. So here I put like a little Starbucks. That's what I like. So this is a Starbucks cup. And, you know, so every day I had to get out of the house and I had to go to Starbucks because I wanted the caffeine. And if I didn't have the caffeine, and I started out small and I had to go like bigger and bigger over the course of, you know, 6 months or so until I was getting the largest cup they had. So in a way, I was dependent on that drug, the caffeine, when the body relies on the drug. And then sudden stopping or cessation of that drug, and in this case, we're going to stick with the caffeine example, sudden stopping can cause harsh symptoms. So if I didn't get that caffeine in the morning, or by about maybe 10 o'clock in the worst case scenario, I was feeling headachy. I was feeling, I wouldn't say jittery, but I definitely was feeling a headache, and it felt better when I got that caffeine. That's tolerance. Now, tolerance, dependence is not addiction. You can be addicted to golf. You could be addicted to a particular TV show. When it's related to drugs or alcohol, it is really called these days substance use or substance abuse disorder. And what that means is even with no medical benefit or despite health consequences or despite legal consequences, despite social consequences, that individual must have that drug. Now, even though drug tolerance is predictive of chronic drug use and dependence, it's not necessarily so. So somebody could be tolerant, not dependent or addicted. You could be, if you're addicted, you probably have dependence and you have tolerance. But they're three distinct different things. So at this point, I'd like to focus on drug tolerance. And what are the types of tolerance? There's cross tolerance, there's metabolic tolerance, and there's functional tolerance. So cross tolerance is exposure to one drug can produce tolerance to other similar acting drugs. So for example, there's opioid tolerance. If somebody has been using morphine on a regular basis, there's probably some cross tolerance over to another opioid medication such as hydromorphone. The person may not be, if they're tolerant to morphine at a certain dose, they probably are not 100% tolerant to hydromorphone, for example, at that same dose, but they are more tolerant as compared to a opioid naive individual. Then we have metabolic tolerance, reduction in amount of drug which reaches the site of action. And one of the best examples that I can provide for this is with alcohol. So there's different pathways in which ethanol is metabolized and eliminated, but we know when going through the CYP enzyme that as somebody starts drinking alcohol, they build metabolic tolerance, which means the ethanol is being more rapidly metabolized, and that person can drink more than, again, an alcohol naive individual. And then we have functional tolerance, which is reduction in the reactivity of sites of drug action. So even though you might just get used to having the drug in your system, so say it's alcohol and the drug makes you sleepy at a certain concentration. Now all of a sudden, you're not outwardly manifesting any outward signs of the adverse effects associated with the drug. It doesn't mean you're not having cognitive impairment, but you do have maybe some functional tolerance to the drug. There's also acquired tolerance, and that occurs by repeated use of a drug in an individual who was initially responsive. An uninterrupted presence of the drug in the body favors development of tolerance. So what that means, it's not somebody maybe using a drug or an illicit drug, let's say, once a month, because over the course of that month, the body is going to metabolize and eliminate the drug. But this is an uninterrupted presence. So if it's a medication, maybe the person is always at a steady state concentration because they're using that drug on a routine basis. And the same would hold true for an illicit drug. And this is why when interpreting drug concentrations, and you want to take into account tolerance, because the toxicology report, again, doesn't provide you that information. This is why toxicologists at times will ask for the prescription records and if it's being filled on time or how many pills are left in a bottle, because somebody wants to look to see if that individual had an uninterrupted presence of drug in the body. If yes, that person most likely was tolerant to some of the adverse effects associated with the use of that drug. So it's an important point to consider, this tolerance. Also, this is another example that comes from the Journal of Analytical Toxicology. Some of the most complex cases to interpret involve patients who are in palliative care or hospice care and are taking large doses of medication for pain management purposes. And this article really says it the best in regard to this specific drug class, which can be extrapolated to other drugs as well. It says development of tolerance to opioids results in decreased CNS depressant effects and the potential for increased dosing requirements to achieve the same effect. So as the disease progresses and there's tolerance to a particular drug, that person needs more drug. Therefore, individuals can achieve concentrations of the active drug, in this case hydromorphone, within their system well in excess of a concentration that may be considered toxic or fatal in a non-tolerant individual. So as we list all the things that somebody wants to take into account when doing an interpretation, it's not that easy to say, oh, there's fentanyl here. It's 40 nanogram per ml. Therefore, the fentanyl caused their death. Maybe it did, but you really want to look at other factors as well, taking into account the possibility of tolerance. This is a mathematical representation of what tolerance looks like from a dose response perspective. The x-axis is dose, and it's plotted in log form. And the y-axis is a quantitative response. The dose response curves are simple and practical ways to visualize the concept of tolerance. No matter the mechanism of tolerance, so we spoke about 4 different ways before. We had cross tolerance, metabolic tolerance, functional tolerance, acquired tolerance. But no matter the mechanism or mechanisms by which a drug exerts its effect, the drug concentration at its intended site of action controls its endpoint effect. So we have some parameters with these dose response curves that we can be aware about. So on the x-axis, this is the dose, and the y-axis is a quantifiable response. What we have here is the green line represents an individual or the same person that's tolerant to the drug as compared to the blue line person or individual. So with tolerance, the curve shifts to the right because you need more drug concentration to achieve the same response. So this is a theoretical way to look at tolerance. In postmortem toxicology, you're not going to do this, but this is a mathematical way to look at that. With repeated dosing, remember we said an individual that has drug always in their system is more prone to develop tolerance. So here's what that looks like. It's that continued shift of the drug to the right. And if you notice, it's just not necessarily one shift in one point of time. So here's drug concentration, here's effect. Here's the first dose, here's a second dose, maybe this is the 10th dose. So it can continually keep shifting to the right. This dose response curve is not a static mathematical presentation. Tolerance is dynamic in nature and can change in a short amount of time from person to person. Having a hard time advancing my slide here. Okay. I don't know what happened. I think it went to the beginning. Let me see where I was. Okay. And the pharmaceutical companies also recognize that tolerance is dynamic and it can increase or decrease over time. So here's an example, fentanyl, the transdermal, the patch system. So here on this is the black box warning. The drug should only be used in patients who are already receiving opioid therapy, who have demonstrated opioid tolerance. And it says patients are considered opioid tolerant who have been taking for a week or longer, at least 60 milligrams of morphine daily, or at least 30 milligrams of oral oxycodone daily, or at least 8 milligrams of oral hydromorphone daily, or an equianalgesic dose of another drug. So here is the mention of the drug is meant for opioid tolerant individuals. You can't be taking this, or you shouldn't be if you're naive to the drug. Also, they give you the definition of what opioid tolerance is. So this here is a living example of that cross tolerance. You can be on morphine, you can be on oxycodone, you can be on hydromorphone, and they even give you the dosages for you to be able to qualify to be not opioid naive, so you can take this drug. So now let's look at some real life information and data. And this is where I say we can all learn from studying drug concentrations seen in the living individual. So where I work, we do analytical testing on postmortem cases, and we do analytical testing for postmortem cases. So this data comes from DUI, DUID cases. So these are cases where somebody was stopped by law enforcement, a blood sample was collected and tested. So on this big blue box, you can see this is fentanyl findings from 2009 all the way up to June 18th, 2020. So right in the middle of COVID. And you can see that over time, not only is there a increase in the frequency that fentanyl is seen in this population, which, okay, that's expected maybe or maybe not. But the main point of this particular data is with this arrow, you can see drug concentrations are increasing over time. So within this population, this is the development of tolerance. So even from like 2016 to 2020, all of a sudden, when most of the people are under 20 nanogram per milliliter fentanyl, you have some up at 40, you have some up at 60, you have some up at 80, you have some at 100. And in some cases, you have fentanyl concentrations in living, granted, intoxicated people over 100 nanograms per mil, but they're not deceased. Now, so now this is from 2021 all the way through 2022 through the summer. And now it's kind of plateaued out in terms of the frequency, but you can see these concentrations within the last year or so. So everybody is here. I mean, there's going to be people obviously under this, but here's like a whole bunch up at 50 nanogram per milliliter or less, 100, 150, you have a person at 200, and you have some people at 250 nanogram per milliliter in a living individual. So now this behooves the question, if you had a toxicology report and the only finding was fentanyl, it would be very, very, like, you could look at that report and be like, you know, 100, 200 nanogram per fentanyl is a lot. And if you had a room and do a center line down the middle of the room, and you said, hey, based on nothing else, you know, is this person living or dead? And you had to go to one side. For me, if it was at 200, I'd go to the dead side if I had no choice. You can't stand on the line and say like more information is needed. I'd go to the dead side, but in fact, for these people, I would be incorrect. So the toxicology results show what is in the sample at the time of its collection. It does not show the frequency of dose, the duration of drug use, if any dosage adjustments had recently been made, or if all the drugs were being used for equivalent lengths of time. So when you look at drugs, of course, we're going to look at additive and synergistic effects. And what if that person always had fentanyl in their system, and then one day they had a whole lot of alcohol and they died? And it's really the alcohol that pushed that person from a living to a deceased state. So sometimes it's also relevant in case history, not only to know what's in the individual at the time of death, but the order that drugs were taken, especially if you get asked about interpretation pertaining to one drug only. I like to do drug interpretation taking into account the totality of drug effects and not just one at a time, but sometimes you get asked. So at that point, I would not want to make the assumption that because somebody was equivalent to one of the drugs they were used, or that was in the toxicology sample, that they were also tolerant to all the other drugs in their system as well. So what do we know about the drug epidemic and tolerance? What can we learn from our practical experience? So in 2021, a record number of Americans died. Over 100,000 people died from drug poisoning or overdose. And this is a nearly 15% increase from the deaths that were estimated in 2020. Now, that primary or the overdose deaths are most likely attributed to the synthetic opioids, primarily fentanyl, and the psychostimulants, primarily methamphetamine. I believe this can change depending upon what part of the country you're sitting in, because there could be regional differences. But we see this continued increase in 2021 as compared to 2020 and 2022, and now we're in 2023. And really not much has changed. And what we've seen is the toxicology people who look at the reports, and we look at clinical reports, we look at law enforcement reports, and we look at postmortem reports. We have seen drug concentrations dramatically increase in living individuals to levels or concentrations that on the surface could readily be associated with lethal outcomes. And NMS Labs, where I work, there's over 20 toxicologists. And every now and then you see a DUID case or a result that comes from somebody that's alive, and we share it for our knowledge to say, hey, look at this person. And so it gives you pause, it gives you some thought of, when you get that question, did the drugs cause a person's death? Can they? Yes. Did they is another question. And when we look at drug concentrations, this is a measuring, like measuring spoons. So we have subtherapeutic, therapeutic, toxic, and lethal concentrations. And one way, even that is a good starting point, is to look at those blood concentrations that have been associated with certain outcomes and that have been reported in the peer-reviewed literature. So for some medications, we know what subtherapeutic could look like. We know what therapeutic concentrations are. And then we know what concentrations have been associated with toxic and lethal outcomes. Reference ranges, reference comments, they are very good starting points. And then you want to take into account the possibility that a person can move from one category to another, because we know tolerance is dynamic, especially with drugs like the opioids and the psychostimulants, where cause of death has been attributed to cases. So keep this gradient in mind, knowing that because of tolerance, especially with the illicit drugs, what might be lethal or what might be toxic or what might not really be at some point can shift over time within the individual. This is fentanyl concentrations in the living in more recent times, from September 2021 through September 2022, for one solid year. So you can see, so this is from the police cases, and now this is more broken out by buckets as opposed to that other diagram, which really just showed the increase in tolerance over time and in recent years that we're seeing. So the range is 0.22 to 230 nanogram per milliliter. The sample size was a little bit over 2,300 people. And you can see in most concentrations in the living, the majority of them are about 30 nanogram per milliliter or less. But look at this. You have people that are 30 to 40, 40 to 50, 50 to 60, onward. We had 18 cases in a living individual where the concentration was greater than 100 nanogram per milliliter. And then remember those concentrations from the previous slide. These are post-mortem concentrations from September 2021 through August 2022. This is 37,000, I guess close to 38,000 different types, or close to 38,000 samples. And you can also see the majority of them sit in this 20 to 40 and 50 concentration range. You can see the fentanyl concentrations and how overlapped they are with concentrations found in living individuals. The same holds true with methamphetamine. So this is methamphetamine in the living from September 2021 to September 2022. And most of them are down more in the hundreds range, but you see some greater than 1,000 nanogram per milliliter, and you could see the breakout of over 1,000. What does that mean? Does it mean 1,001 or does it mean over 2,000? In this case, we had 9 people that were over 3,000 nanogram per milliliter methamphetamine in a living individual. These are the postmortem concentrations. And again, just like the fentanyl, you can see this overlap of concentrations found in the living and the dead. And you can do this strategy really for any drug of interest to you. You can find concentrations that have been associated in living people and concentrations that have been found in postmortem, and you're probably going to see an overlap. And this underscores the need for additional information to do a complete toxicology interpretation. So I just wanted to show you some real life case examples with the question of, what do toxicology test results tell us? So the bottom one is a postmortem case. It's a 25-year-old male with a suspected heroin overdose. So these are all blood findings. And you have fentanyl here at 16 nanogram per milliliter with some norfentanyl. And you're like, okay, it's a 25-year-old and the scene is suggestive of a drug overdose. There's no other findings on autopsy. So, here you go. This is a fentanyl cause of death, and the manner of death is accident. Here above, alprazolam at 58, morphine at 8.7. So maybe that comes from 6-acetylmorphine or heroin. There's marijuana, which, okay. Fentanyl's 140 nanogram per milliliter. So here we have maybe heroin use, looks like low level. Fentanyl at what I would consider a large concentration. And we have alprazolam, another CNS depressant at 58 nanogram per milliliter. And we do have signs of cocaine use, even though cocaine's not found in the individual. This is from a living individual. This person was in a vehicle accident. They exhibited signs of slurred speech. They were lethargic. The person said they're a heroin user and had used heroin, and maybe it looks like they really got fentanyl instead. The person did have some lacerations, but I spoke to the police officer and he said, no, this fentanyl wasn't administered. And these were the findings in an individual that was able to communicate. Maybe not well, that she had slurred speech, but she was able to say that she had used heroin. But look at the disparity in drug concentrations with 2 different interpretive outcomes. Neither of which are wrong, it's just concentrations by themselves don't tell the whole story. So here, would you say this is a drug death? Here we have heroin, we have fentanyl and ethanol at 263 nanogram per milliliter. Now you could say that could be a drug death. you know, that's a high concentration of alcohol. We have heroin here, we have fentanyl here. Certainly these are all CNS depressants. Certainly we can talk about additive and synergistic effects, but look at the case history. History of drug use, struck by vehicle. And that being struck by vehicle was their cause of death. Would they have died if they weren't struck by the vehicle given some time? I don't know. But for this cause of death, they were struck by the vehicle and had blunt force injuries. So here, case history tells the whole story with pathology, and the toxicology is there and might contribute to the story. But the toxicology by itself, if you didn't have some of the case history, you might come up with an incorrect conclusion. Now here's another slide. We have a person asleep in the car, they're passed out, the police is, they're called. Now this person, they were able to complete standardized field sobriety tests, they followed instructions, and they answered questions. So we have benzo, we have cocaine, we have methadone, we have the fentanyl, and we have the xylazine. So person, are they alive or are they dead? Are they dead? Really, in the absence of case history, I don't think you could tell. So to underscore all of this, case history and pathology supports interpretation of toxicology results. If you have a foam cone, and we know opioids can cause pulmonary edema, it's a foam cone, and you have toxicology findings that show the presence of an opioid, and maybe that individual is not prescribed it, and the scene investigation supports illicit use, that helps with the opinion that this is a drug death. You also want to get down to, is there another competing or competent cause of death that could override the toxicology results? So this is just an example. I got this off the internet. It's a picture of a vessel or like an aorta bursting. You know, could you miss that if you didn't do the autopsy? Maybe, but I know toxicologists, us, we're kind of greedy. And outside of the toxicology report, when we come to do a case interpretation, we, for the most part, will ask what was seen on pathology. And so this is a thought question to you. Do you remember in school, sometimes when you got a case history or you got like a circumstance, and then the final question was, did a person die because of the drug or with the drug in their system? Or just, I'm sorry, did a person die because of the drug or with the drug in their system? And then you had to support your answer like an essay style. Remember those questions? So when we do case interpretation, and the question is, did the drugs produce a lethal outcome? Ask the question, and how are you going to support your answer one way or the other? Yes or no? So in conclusion, these are some main points I have to remember. Extreme concentrations seen in some DUID cases show the body's ability to develop extreme tolerance. Remember, we see DUID people, and just with fentanyl, you know, you could have concentrations in the 50s and the hundreds and greater than 100. That's tolerance. Tolerant, or at least compared to people who are using the drug therapeutically as prescribed. Then we have tolerant individuals can have active drugs within their system well above concentrations that may be considered fatal to drug naive individuals. And prescription records, if it's a prescribed medication, are a great way to help determine if that person would be considered tolerant. Also, if a person maybe was in a facility where there was really tight, restricted control of drug access, and now maybe that person that was tolerant is no longer tolerant when they leave the facility. So also a person's movements in the days leading up to their death may be very important to know as well. And in lieu of that, there might even be some witness observations. Death due to drugs cannot be inferred solely based on concentrations, or should not be, and this is my opinion. Evidence at the scene and on the body helps to triage the case and ascertain if the death warrants an autopsy. I know in some jurisdictions or all over the country, there may be processes or procedures put into place over who gets an autopsy and who doesn't, but evidence at the scene and the body can help determine if that autopsy is needed, or if toxicology testing by itself in combination with the case history will suffice. There is a potential, however, if you only do this external only exam or no postmortem workup, the question does exist. Could there have been something that's been missed that could have been a direct or contributory cause of death, such as disease or trauma that supersedes the drug or drugs as a cause of death? But you can always, again, use that strategy of looking at reference range concentrations, but also pulling very recent data and scrutinizing what we're seeing in the living to better understand how to interpret drug concentrations in the deceased individual. And with that, I would like to conclude this presentation. And if there's any questions, respond to those. Thank you.
Good afternoon, everyone, and thank you for your attention during today's webinar. My name is Reynold Dyson, and I am with NMS Labs, and I will be following up with the questions submitted during the presentation for Dr. Labay to review. So, Dr. Labay, the first question we received is it not more appropriate for forensic pathologists to interpret the scene and autopsy findings?
Ultimately, it is the pathologist's purview to make cause of death, or to finalize the cause of death and manner of death decisions. It's just that as toxicologists, we will get asked for help with that interpretation.
Okay.
And when we get asked for help, just like anybody else, we don't want to be doing it just by looking at the drug concentration in absence of other information, because the toxicologist will say, yeah, you know, you're going to end up with probably, or you could end up with, yeah, these concentrations have been associated with the lethal outcome. These concentrations have also been seen in people who are alive. So we work in conjunction with pathologists and maybe death investigators to do a complete interpretation of the toxicology results, or to better put that toxicology result into context for the entire case. Certainly we'll look at prescription records to form an opinion about tolerance, if there was a recent dosage adjustment that didn't end well for the patient. And then ultimately, sometimes in court, we'll get asked about our opinions regarding that drug concentration. And so we want to be able to talk about the drug, but put that into context too, because we know a drug concentration and its finding is not one size fits all.
Understood, and thank you. Next question. So we have a couple questions regarding sample collection, or the appropriate samples to collect for analysis. The first one is, where is the preferred place to obtain blood for testing? If subclavian won't give up any blood, may we obtain from the heart and get the same results?
Well, the preferred source is blood, but the source of the matrix is blood, but the source would be a peripheral source like femoral. So if femoral is unavailable, subclavian is unavailable, you're going to have to get blood from someplace else. I've seen blood people take from the iliac. But, you know, one thing with toxicology too, and we really didn't touch base on it here in great detail about postmortem redistribution. There's not really a mathematical way to figure out if the drug has undergone postmortem redistribution. So in combination with just looking at the drug, its concentration and other findings, we also consider if the literature tells us if that drug could have undergone postmortem redistribution and take that into account. There's no guarantee that what you find in subclavian will be an identical or similar concentration that's found in another blood source. If needed, you might be able to also interpret the blood finding with some vitreous findings as well, because the vitreous is less prone to the postmortem redistribution because it's, you know, in the head and away from the body.
Yep. Okay. Thank you. And that leads sort of to another question around vitreous. Is it true that vitreous will give more detail on drug usage than blood?
So not in terms of tolerance. A toxicology finding, be it in blood or urine or vitreous fluid, shows you one moment in time. It shows you what's in the sample at the time of the testing and theoretically what was in the sample at the time of its collection. In terms of duration of what I think maybe, so this is a point too, sometimes drugs can persist in the vitreous as compared to the blood. Heroin is a prime example of that, where you might find morphine in the blood and 6-acetylmorphine in the vitreous fluid, and that helps you identify the source of the morphine because it just persists, or 6-acetylmorphine persists longer in the vitreous fluid as compared to blood. So the vitreous fluid provides that the advantage from that standpoint. But in terms of chronic or like chronic and repetitive drug use, I don't think the vitreous fluid would tell you that. It's just a moment in time.
Yep. Okay. And thank you. For testing purposes, do we prefer first blood drawn at a hospital or postmortem fluids?
I would say, especially if there's a time lapse from the time of hospital admission to the time of death, you're going to want those hospital admission samples. And if they're available, you want to collect them whether they get tested or not. One of the main differences between a hospital collection and postmortem collection most likely is the tube type. Postmortem, you know, the recommendation is a gray top tube, but in a hospital sample, it might be a purple top tube. And some drugs just aren't as stable in the purple top tube, such as parent cocaine relative to the gray top tube. So for some testing, it might be important to test both the tubes, but in general, you want to get the hospital admission samples, and they are the preferred sample to test, especially if there's sufficient volume there, and if there has been a time gap from the time of admission to the time of death.
Great, thank you. Next question. In an elderly individual with multiple potentially terminal diseases and overdose, and where an overdose cannot be ruled out, would you still believe a full autopsy is a necessity?
So what was an elderly?
So I'll repeat the question.
Yeah, and they're like in
so,
hospice care, you said? Or,
it's an elderly individual with
yeah.
multiple potentially terminal diseases,
Mm-hmm.
and an overdose cannot be ruled out. Would you believe a full autopsy is a necessity? So they may
I
have been
would say,
long-term care,
for
Laura, and
me,
then,
I don't make that final decision. I do think the hospice and the palliative care populations are different in that usually there's very well documented clinical history that will support a terminal diagnosis or outcome. I know at times, and I've been involved with these cases where now there's an allegation that that person in palliative care, quote unquote, wasn't that sick and they had time to live, and there's suspicion about somebody giving somebody a drug that they shouldn't have or too much of a drug. In that case, I think the clinical documentation and toxicology would suffice myself from a toxicology standpoint, but I would want to make sure there's really good clinical documentation about what drugs they were allowed to take, the dosages of the drugs, so I could start to look at their blood concentrations in context to that prescription records and take into account any disease processes that may affect metabolism and elimination of the drug.
okay, thank you, Laura. One more question regarding the presentation is, how do you use metabolite concentrations to interpret tolerance versus acute toxicity, for example, with methadone?
Yeah, so methadone has several metabolites, and there's EDDP. And I think I can almost quote you what Basalt says. It says, methadone concentrations between the people who are tolerant and non-tolerant greatly overlap. And the presence of EDDP can suggest prior use and therefore tolerance. And the same would hold true for some metabolites, like an antidepressant, such as amitriptyline that metabolizes to nortriptyline. Maybe you have equivalent concentration of nortriptyline. Maybe it's at a greater concentration than the amitriptyline. But in some context, you could use the metabolites. But even with EDDP as an example, yeah, it's present. We most often see it present, and it's suggestive of prior use and tolerance. Okay, but it still doesn't tell you necessarily what kind of prior use it was and how tolerant that individual is. I don't think you can look at EDDP and be like, okay, this equates to really tolerant or naive. Just, even the most tolerant individual can overdose too. So it may be helpful, maybe not too. I hate to be all waffly like that, but that's what I can say.
No problem, Laura. And thank you very much. Those are the scientific questions that were related to the presentation. There were a couple of administrative questions that I would like to address. Are there CEUs given or certificates of attendance for participating in this webinar? The answer is yes. A certificate will be provided to all attendees via email as a follow-up after the webinar. However, this presentation is not broadly approved for CEU credit, but may be accepted by your local accrediting organization to fulfill continuing education credits. So the presentation itself is not a CEU presentation, but your local coroners association or health department may accept the presentation or the certificate to fulfill some of your continuing education credit requirements. Excuse me. And the final question we have is, may we have another webinar on how laymen can read the toxicology report, not in detail, but highlights?
Yes.
Excellent suggestion, and we will certainly consider this topic for a future presentation. We wanted to let you know, wanted to thank you all again for attending today's webinar presentation. All of the attendees will receive an email with a link to the webinar recording. And you will, once completion of this presentation is done, please complete the survey that will follow the presentation afterwards and provide your feedback on this and other topics that you would like to see presented by NMS Labs. Thank you very much and have a good day.